Hello, everyone, and welcome to our monthly December 2022 ECHO session. My name is Francis Ochen from the African Society for Laboratory Medicine, and I'm going to be the moderator for this session today. As usual, our session will run for 1 hour. We'll take one presentation and then go into the questions and answer discussions. Kindly join the discussions through the chat room, providing questions and alternative ideas that you may have on the topic. We have language interpretation services. Please get to the bottom of your screen and choose the language of your choice. Do not keep on the neutral channel. Before I start today's session preamble, we also note that today is World AIDS Day, where people around the world gather and unite in really recognizing and supporting people living with HIV and remembering those that we have lost through illnesses. We also note that the theme for this year is Rock the Ribbon. And as we do so, we're supposed to then really have the desire to secure the rights, fight stigma and discrimination among HIV positive people. And I know each one of us has made our own contributions towards this, and we would want to thank you for our contribution, the modest contribution that you continue to make in the fight against HIV and AIDS. In our session today, we look at efforts towards taking out testing in silos and consolidating a structured use of existing investments. In today's session, we will share practical insights on integrated testing for hepatitis B and hepatitis C to align with the WHO goal of triple elimination of HIV, hepatitis B, and syphilis. And in so doing, we look at Nigeria and we will discuss their implementation experiences at the point of care sites, their existing TB and HIV infrastructure that relates to this. And to take us through this, we have a presenter coming in to share with us the experience from Nigeria. Our presenter today is Chukwuemeka Agwuocha. Agwuocha is the manager of hepatitis and COVID-19 therapeutics at Clinton Health Access Initiative in Nigeria. He is a public health specialist with a lot of passion in saving lives and improving health outcomes. He's had over 12 years experience in both public and private sector. And Agwuocha started his career in the pharmaceutical industry as a sales representative with a focus on respiratory tract infections. He joined CHAI Nigeria in 2014 and has grown through the ranks. Most recently, he joined the COVID-19 Therapeutics program to accelerate access to treatment aimed at delaying progression from mild to severe cases of COVID-19. Colleagues, join me in welcoming Agwuocha to take us through the session. Agwuocha, over to you.
Thanks, Francis. Thank you so much. And good morning, good afternoon, good evening, everyone, depending on where you're joining us from. My name is Chukwuemeka Agwuocha, and welcome to this LabCoP session. The work with Clinton Health Initiative. And for those who are not aware, CHAI is actually a global health organization committed to saving lives and reducing the burden of disease in low and middle income countries globally. We work in 35 countries with leadership of governments and ministries of health to strengthen and build resilient health systems, where we aim to achieve transformational impact by accelerating access to innovative treatments and diagnostic technologies. Today we'll be looking at integrated hepatitis testing as part of WHO response to triple elimination for HIV, hepatitis, and syphilis. And as Francis mentioned, today is World AIDS Day, and it's a good time to talk about strategies to achieve elimination as we work towards the 2030 goals. But our focus will be around hepatitis testing sharing our experience here. So we'll start with the overview of the hepatitis landscape, then touch on the challenges, and then we go into the meat of the matter, which are around the interventions, and then we'll look at impact, of this on a broader scale before we conclude and take questions. So viral hepatitis is simply, known as liver infection, which has to do with inflammation of the liver. And there are two main types which are public health important: hepatitis B and C, usually spread through contact with body or blood fluid from an infected person. Now, the global picture is quite alarming, with a heavy burden of 354 million persons infected and causing 1.1 million deaths annually. In fact, it is recorded that last WHO reports, we've seen 3 million cases of hepatitis B and C occur yearly. Now, if you look at the graph on the screen, looking at, it gives you an idea of the burden across different regions and continents. You will see that Africa contributes very significantly to the global burden for hepatitis B, about 66% of the cases we've seen. And one could attribute this to the fact that a lot of African countries are low and middle income countries, and that's a region where we see a lot of burden of this disease. And hepatitis B transmission is basically through vertical transmission. And thankfully, in 2020, WHO came up with the guidance around eliminating multi-trial transmission, and giving the birth dose vaccine is key to reducing the transmission of this disease in newborns. However, we can see that we are still at 17% coverage for birth dose vaccines, which contributes to the high burden we've seen in Africa. Back then in 2016, we had got the WHO guidance around hepatitis C, coming with the simplified treatment algorithms, using the drug-acting antivirus to manage the disease. So CHI has been working across 7 countries to accelerate access and uptake to this innovative treatments. And we have market shift around the pricing, coming from more than $1,000 to as low as $80 per person for these treatments. So I will be sharing with you, our experiences around the HCV landscape, how we've been able to improve access and overcome some barriers to HCV testing, and positioning the integrated testing platform as an opportunity to work towards triple elimination of hepatitis, HIV, and the STI, syphilis. So next slide. Coming into the Nigerian context, which is not too far from Nigeria has an 18 million, Nigeria is estimated burden of hepatitis at 18 million persons of hepatitis B and C together. While we have seen average prevalence rates of 1.1%, we've seen some variations across regions. If you look at the graph in the map of Nigeria, you will see 2 shaded regions. One in the north central region, Nasarawa State, where positivity rates run as high as double digits, far higher than the national average. And with a population of about 2.6 million persons, it's estimated that 200,000 persons are chronically infected in Nasarawa. But then, despite this huge burden, unawareness still remains a huge gap, just the way what we have seen from a global picture. Then towards the left, the lower side, Lagos State, which has positivity rates like the national, but then among the PLHIV cohorts, we've also seen a very high burden. The Lagos State, has some systems in place for diagnostics, but then again, access to reagents remained a huge challenge. But we'll delve into the real barriers, for limiting access to these services in our next slide. Next slide. So looking at the barriers, there are 4 major barriers. One is around the high cost. Hepatitis, unfortunately, hasn't got that robust, financing, unlike other programs like HIV, TB, malaria. So a lot of patients have to pay out of pocket. And then prior to CHI's intervention, they had to pay as high as $140. And then also had to travel to as far as 350 kilometers for certain services, either in the private or public sector. We've also seen long turnaround times, for this test. It went to as high as 90 days. And what this results in is that limited treatment access, and in a period of 54 months, we had only 21 treatment initiations in across these two states. So the aim of the project was to see how we could decentralize care, accelerating access to diagnosis and treatments across the states, and also leveraging existing technologies, laboratory infrastructure to drive diagnostic testing. Looking at Nasarawa state landscape, where we have just 13 GeneXpert platforms, which we're offering TB testing. The idea was to leverage this platform to integrate hepatitis testing on these platforms. And to achieve that, we explored a four-pronged approach. The first was, having a pre-selection of the sites, looking at the available spare capacity, which I'll delve into in the next couple of slides. But most importantly, obtaining that stakeholder buy-in to ensure that the relevant stakeholders at the national level, at the state level, the facility level are on board with this policy shift and are committed to this process. And the third bit was around operationalization, training of the healthcare workers, the lab managers, and the lab workers to ensure that they have adequate capacity to provide this testing. And last, at the testing sites. So the absence of commodities, what we did was to explore a private-public partnership approach where the pharmaceutical companies were on hand to donate or to provide some feedstock for testing. Next slide. So just to give an idea of the advantage the point of care testing will bring. Previously, before coming through with this approach, the conventional testing mechanism had patients have the referrals to the testing site, and in that process, there's high loss of follow-up observed. When tests are performed as well, they not all come back to the facility with the results. So all this delays clinical action. So you see a 90-day period from the time of facility visit to the time of clinical action. But with the near point of tests, the goal was to see that within 2 days, this is condensed such that in 24 hours patients are placed on treatment, and that way limiting progression to severe disease. Yeah, next slide. So moving into the integration piece of the work. So we identified one of our facilities, our high burden facility, which is the Dalhatu Arab Hospital in Nasarawa, for this piece of work. The baseline period prior to integration was about 54 months period, but our intervention period was 13 months, and the key goal was to measure the impact of integrated TB HIV testing on the GeneXpert, as well as the feasibility and stability of this process. Furthermore, we're also going to look at the uptake of diagnostic services, and ultimately, how does this affect treatment uptake, seeing that there are available curative treatments for hepatitis C. Certain indicators to measure this work were around looking at the testing volumes, batch utilization, and other parameters. So a critical component to guide the site selection was to understand the available spare capacity and the site. So CHI developed a modeling tool which provided that idea to really compare the GeneXpert utilization rate of facility when used for only TB testing as opposed to integrated testing. So if you look at the slide, you see the first piece, which is a set threshold. So with these two platforms that had less than 25% available spare capacity were not suitable for integration. So it was important to really understand this before we proceed. And then again, it also gives you a laboratory scenario where you can compare multiple integrated approaches, more than one disease area. Like if you want to think about TB, EID, HIV viral load, HCV integration. Now you need to compare and confirm if you can integrate on this platform. The reason being that there could be increased volumes in any of the tests, and when that happens, what it will lead to, long turnaround time, delayed testing on the platform, and that's not the key goal of optimizing these platforms. So it was important to really understand this component before proceeding with the integration model. So with this in mind and with this information, we went forward to integrate, across our site at Dash. But then we experienced a hitch. The initial available capacity was below 25% at the facility at the point of integration. What this meant was it wasn't a good fit, but then through advocacy to the laboratory and the leadership of the facility, we were able to advocate for an expansion in laboratory work times to accommodate the increased, to accommodate the HCV viral load test. So with that increased laboratory work times, we're able to expand the available spare capacity by 26%. So what this meant was it was okay to integrate on this site. Looking at the volume demands for TB and HIV, for hepatitis, sorry, it was going to accommodate both volumes. So this was our scenario, and with this we went ahead to integrate on this platform at Dash. Next slide. So after the first 6 months, we thought to reevaluate the progress at the facility to confirm that we were still safe to proceed with this process. And we saw that if you look at the graph in the middle, with the increase or with additional HCV volumes, we're still below the target optimal optimal utilization. So it was good, and turnaround times remained very, very stable, coming down from 90 days to as low as 1 day. And most importantly, the TB turnaround times were not impacted. So it was okay to continue with this process. Next slide. So having successfully integrated on the first platform, we thought to expand decentralized testing to multiple sites to improve access and accelerate uptake of this test. The first phase was in two district facilities in 2017. But these were low volume sites. So being low volume sites, there was no need to increase testing time because they had really significant unused capacity. The second phase was additional 4 district facilities, which was in March 2018, about 5 months later. But in this scenario now, we had a combination of high volume sites and low volume sites. Taking lessons from our initial experience across the earlier 3 sites, it was easy to just make necessary changes and have the advocacy conversations around the integration model along the facilities. So what we saw in the initial outcomes were a rapid increase in number of patients accessing viral load testing from March to December, as high as 146% increase. And with the expansion to more district facilities, we're able to build that referral network through a hub and spoke model. And then we also saw increased visibility of some low volume sites because they were now serving as hubs for HCV viral load testing. So recall that we're going to look at other parameters in terms of operational feasibility. So patient impact. So here you are. With expanded testing, rapidly we saw increased number of tests on the GeneXpert platforms. We also saw a decline in cost. Integrating on the GeneXpert already gave us that opportunity to reduce costs from as high as $140 to $170, and also we could see faster turnaround times coming down from 90 days to about 1 to 2 days, and ultimately more treatment initiations. From the operational angle, more healthcare workers were happy, with this approach because they could really provide this service to people in need. And also, most importantly, the TB testing was not impacted as the turnaround times were still within 24 hours. Next slide. So looking at the care cascade more holistically, we could see that we saw increase across the care cascade from screenings, to viral load testing and environment patients placed on treatment. Just so for those who are not aware, the HCV care cascade is in 3 main stages. You do the antibody testing to confirm patients who have been previously exposed to the virus. The second step is to have a confirmatory HCV viral load testing to ascertain presence of the current infection. And then the third piece is to place on treatment after you've done your liver staging. So this cascade just gives us an idea of what was looking like from the baseline period to the post-integration period. And we could see drastic increases in number of patients accessing these services because it was now available within the facility. They didn't have to travel long distances to get this test. So ultimately, integrated testing was really a strong catalyst for treatment initiations for those for viremic patients. Going forward, our plan was to think about how do we expand this to other program areas? How do we strengthen linkage to care for seropositive patients, advocating for increased platforms, to drive more testing, and most importantly, use the evidence we've seen here to advocate for financing for diagnostics and treatment. Because I mentioned the hepatitis program is really not enjoying that robust enough funding, so this could be an avenue to advocate that look, these cases are existing and they are present, and we need to see how we could, bridge the gap for the ordinary, for that man in the rural area that's unable to afford these treatments. Next slide. So we also looked at, an annual review, 2019, 2020, and 2021, to really understand, is this process something we can continue to move forward? Is it impacting on the TB volumes, from a regional angle? Do we need to make some adjustments? And interestingly, we saw that, we hadn't even optimized the platforms in the States. It was still, we still had massive unused capacity across the platforms in the States. But what we observed was in 2020, we saw increased error rates, which we attributed to maybe the pandemic, but with healthcare worker training and also review of the testing operationalization at facilities. We have to make design modifications to ensure that error rates were back to acceptable figures in 2021. So it was safe for us to continue with this process. Yeah, next slide. So here we're sharing with you some feedback we got from the healthcare workers, on the use of this technology, the integration model. We had feedback from the laboratory HOD, we had from the TB focal person, most importantly from the gastroenterologist who have been driving this process at DASH. And coming from a place where she was unable to recommend testing for her patients initially, seeing high loss of follow-up, unable to really practice as she would ordinarily, to a place where she just recommends this test, you go to the laboratory, they get it done, and have treatments available, and they're more affordable. So she was delighted to see this, and you could see on the screen, how much she shared her excitement. Next slide. So the next part of this presentation is around the benefits. So how has this impacted on other programs? We had mentioned the point of care testing earlier for hepatitis C, but this is more around HIV, where, as we know, for HIV program, we have that sample collection, sample transport, to the centralized sites. We have the testing, then the testing done, results returned in consultation. And I mean, so that shows that the a lot of points of loss of follow-up, either as sample loss or sample wastage or sample integrity, or even differentiate along the care along this pathway. And before it goes through this process, it takes about 30 days. But using the point of care technology, it was also aimed at condensing these visits or this process to just one facility visit, and patient is able to get the right clinical action. Next slide. So also with the point of care technology, we could see that we had multiple strategies to improve testing. The first is around on-site testing, where you have samples come straight from clients to the laboratory to perform this point of care testing. The second piece is where you have the hub and spoke model networks. Recall that we had expanded to some district facilities, so that provided a hub and spoke approach to this. The third piece is where you also have multiple entry points, patients who are in the lab, who need this testing done. We could just collect their samples and send who are in the wards, just get the samples and send to the laboratory for testing. And the fourth piece is, you could actually have hepatitis test run, multiple tests run on the platform. So this created that opportunity to just have all this happening at the facilities. But just to share with you in detail, the HIV program, how they had integrated on the EID. Next slide. So they had also a pilot phase 1 done across 8 states in the country, and the idea was to integrate EID, HBV, and HIV viral load on the GeneXpert, also taking into cognizance the initial criteria around site selection to ensure that there's available space capacity as well, so we don't have the case where we compromise TB testing or other tests on the platform. So what we saw was, next slide, increased testing across the sites over a 1-year period, going from no tests done to over 2,000 EID tests done on these platforms. You could see that they had the highest volumes in July and August, but a decline in September, which was attributed to not limited availability of the cartridges. And also we could see that some takeaways that we could see from this result is that integrated testing is quite feasible in GeneXpert platform, and it's important to also determine availability of unused capacity to ensure smooth operationalization and smooth flow. And from the policy angle too, we could see the national program and PEPFAR willing to support this process as a way to expand EID testing and also ensure early clinical decisions for those infants and newborns. Next slide. Also, from the policy end too, as I mentioned earlier, this was an opportunity for us to generate desired evidence for advocacy to the government, and looking at the effective diagnostics and the tools available at the community level, the presence of curative direct acting antivirals, and also through market shaping and price reductions, putting all this together and the results that we had recorded in the states, it was easy to advocate to the government of Nasarawa and the committed to HBV elimination. But we know that this elimination is actually cost-effective, is really cost-intensive, but looking at collaborations to drive this process. So currently, Nasarawa State government is leading the elimination efforts in the state, and through this model, to be able to achieve reduced pricing for out-of-pocket patients accessing these services. And with increased volumes, with elimination commitments, we've also secured further negotiations around pricing, and most importantly, strengthening service delivery approaches. But the important thing is the fact that this has really been an opportunity to generate desired evidence to have that policy shift at the government level. Next slide. So just to summarize, the benefits of the integration model, which we have seen not just in our local context, but also globally. We've seen, as I said earlier, the policy bit, generation of policies around routine testing and for these different disease areas. We've seen WHO recommend integration models to drive HIV and TB programs. Long turnaround times being reduced and allowing for early clinical decisions coming from as much as 90 days, 30 days to 24 hours. Improve case finding for patients who are positive and linking them to care. We've also seen device optimization, tests, HIV, HBV done on the platform, hepatitis as well. Even when the pandemic struck, this whole optimization was really key to improve COVID, to reinforce COVID testing and ensure availability of the PCR testing across the country. And of course, improve reporting. We're now looking at establishing interoperability measures to see how can we look at the data from the TB platform to understand where we need to deploy the right interventions. And of course, the market shipping piece, which is quite an interesting piece, where we have seen the increased volume demand setting the tone for negotiations and also reduce pricing. So really, there are a lot of benefits that we have seen from integrated testing beyond the laboratory, but also on a broader scale. I think this is my last slide. Yes. So thank you so much, and happy to take your questions at this point. Over to you, Francis.
Thank you very much, Agwuocha. I think initially I got the name not very right. Very fascinating, very informative presentation. And indeed, integrating testing is possible if it is well planned and implemented as planned. And of course, drawing and learning from the lessons as you go along to improve even the improvement of your test integrations. You've taken us through improving your testing journey. You've actually also indicated the fact that about 95% of Nigerians actually wouldn't know their status in terms of hepatitis infection. You've also covered some of the challenges and considerations for integration. And this is really, really important. We've had so many questions coming through. Colleagues, keep your questions coming so that we can then deal with those in the next 20 or so minutes that are available to us. Thank you also, Kenneth. Kenneth is really providing some of the answers to the questions that are coming through the chat, and that helps. And we will still take some of the questions even when the answers are provided so that it is clear to everyone. And our first question is coming in from Kamara. And I just want to twist it a bit for Kamara. He is asking if there is a mechanism for preventing vertical transmission of hepatitis. And I know Kenneth has indicated this, but do you want to say something to this effect, Agwuocha?
No, I've just seen a response by Kenneth, and I think that's actually correct. It's through timely vaccinations in 24 hours of delivery of the newborn. That's the surest way, and of course, subsequent vaccines at 6 months, at 6 weeks, 10 weeks, and 14 weeks. But yes, unfortunately, a lot of African countries haven't really introduced the birth dose vaccines. But it's important that this starts to have these conversations to ensure that we have these birth dose vaccines available, and also taking a step back too. It's good to also have systems in place to drive screenings for pregnant women, so we can isolate those who are those who are positive and put them on TDF prophylaxis prior to delivery once they meet the set criteria by WHO.
Okay, thank you. Now our next question is coming in from Anafi, and Anafi is asking, and he starts with a comment that you made mention of some shortcomings in testing cascades using the conventional methods or platforms, including loss to follow-up, among others. But he also notes that not all countries are able to budget and accommodate point of care testing. And so what are some of your insights related to improving the shortcomings with conventional methods, other than just saying that then the only available option is point of care, which is not what you said anyway, but just your comment on what are some of the things that we can do to deal with the shortcomings with conventional methods?
So I would want to approach it a bit differently. I would say in our own scenario, we didn't have to budget, or the government had to budget specific funds. It's just leveraging existing technologies and platforms here. So the first piece may be to understand, are there opportunities for us, for the country, or to identify this platform that they can leverage initially. If that's available, then they can leverage, they can integrate on the existing platform. But where it's not available, then that talks about strengthening the whole pathway around conventional testing. And I know our labs team has done a lot of work in terms of the LIMS pathway, having a system where a barcoded system where you're able to track these samples from having the most sample logging approach to see that from the remote, from the sample collection side, you start to track the samples before they get to the testing side to ensure we reduce loss of follow-up from sample collection or sample transport, and also training healthcare capacity to ensure that the samples integrity is maintained to the testing lab. But so in the absence of opportunities for integrated testing, the centralized approach would just be to strengthen that whole referral pathway and to ensure that loss of follow-up is usually minimized. The good thing is for the HIV program is more around sample transport. So it's more like the sample transport pathway. For hepatitis is more around patient referral, and that's where it becomes a bit tricky, because if hepatitis, which is largely asymptomatic, so patients are not really having that clear signs that they are positive. So it now becomes a case of traveling long distances to access tests when I don't feel like I have anything. But that's where counseling comes into place, effective counseling comes into place, encouragement to seek care. But ultimately, it would be good to look inward to the opportunities for integrated testing. And thankfully, we have digital platforms really rapidly spread across multiple facilities. Over.
Thank you. A very elaborate response, and I thought we needed to hear that from you, Agwuocha. Now, the next question, I'm going to try and combine two questions, one from Jean-Pierre and Anafi again, on some of the challenges or barriers to integrating testing. And Anafi points out one, Pierre leaves it in general, but is data management a key challenge in integrating testing? Because we seem to see that when more facilities are involved in testing, then pulling together some of the numbers become a challenge, but among other challenges. So your take on some of the barriers to integration and relating it to data management.
Absolutely, Francis, that's really very correct. When you talk about integrated testing, you talk about how do you now, look at data components, how do you begin to track these systems, and get the real outcomes, especially the testing that's done across different areas. But the good thing is, most of these platforms are linked to different software technologies that on the back end are able to, record this testing, because you need to feed these samples into the software, and that's where the digitals are put in. So when results comes out as well, it feeds back into the software. So from the back end, you're able to see this data, but then it's not really available, because it's kind of it's not really available from manufacturers for use. So possibly we could have to think about advocacy to the owners of the Genesis platform being surveyed to say, okay, if we're moving towards integrated testing, how do we ensure that from the back end, we have interoperable mechanisms to link the data systems from, your end to other national, reporting systems like the HIV reporting system, the hepatitis and all that. So with that visibility, you're able to make the data flow. So it's possible to track from the back end, but now it's creating that interoperability systems to create that visibility. So and after your question for Nasarawa, being a just limited size, we've been able to use paper-based mechanisms because we need a level of funding to create interoperability. But with HIV program involvement, then they created a kind of light system that created interoperability to see how that visibility into the reporting at the back end. I don't know if my colleague Jibrin is here to just share a bit on the back end around the experience with the EID data management systems. Jibrin, are you on the call?
Okay, my colleagues will try and locate him and give him the rights to be able to speak. And yes, so as we work on that, let me just take on a few more questions for you. I know you may want to take a breather, but the next question is really specific to data and co-infection. And this is coming in, and the gentleman already is asking, do you see about 90% to 100% of your patients with hepatitis B also co-infected with HIV and TB? And if it is not within the 90 to 100%, what is the prevalence of co-infection in this population, those that have hepatitis B, if you have the numbers?
Okay, thank you, Francis. So for co-infection, what we can speak to is the HBV, HIV co-infection. We had, I think on the third slide I had shared the country landscape. And from the last survey that we had in the country, we had an 8.9% co-infection rate for hepatitis B and HIV. We've not really, taking time to delve into that data around hepatitis B and TB. So that's what we have now, 8.9% co-infection rate for hepatitis B and HIV.
Okay, thank you. The next question, and I will then double check if your colleague has been identified and he can make a comment on data management from the back end that you needed support in. But the next question is coming in, and I know that you may have the test protocol for each of the point of care testing, where you start and where you end, and also for those that are positive, what is then done for them, or the treatment regime that they go through, but also the tests, the other complementary tests that they may take. But this question is coming in, and the gentleman already is asking, do you conduct serological tests as well? And do you do some biochemical tests for those that come in to do their hepatitis testing, whatever their final result for the status of hepatitis infection is?
So yes, so for hepatitis C, which I mentioned, while I was presenting, I said that I was trying to share the cascade. So you have, the initial screenings for patients, antibody tests, and those who are found positive to the antibodies as, are referred for the HCV RNA testing to confirm really it's a viral load test to confirm the presence of active replicating HCV RNA viruses. And where they are confirmed, we now proceed to, the other biochemical tests, as you mentioned, to determine the liver staging, to really obtain what we call the APRI score. Now, with the APRI score, you're able to determine patients who are cirrhotic and those who are non-cirrhotic. So that's the criteria. So there's a cutoff point, less than 1%, less than 1 for the APRI score. I'm usually not, well, So actually, this less than 1 year actually found to be actually non-cirrhotic patients, and they go on a 3-month therapy. But above that are usually cirrhotic patients, and they are placed on 6 months therapy. But most times, usually we like the specialists to manage those cirrhotic patients, so they could run some other detailed tests, really understand if there are other things to look out for. So I think that addresses the question.
Okay, so again, Kamara is asking, I'll check this before we try to locate your colleague. So Kamara is asking, do you detect the viral DNA by PCR after a prolonged infection? And I know that the trouble will be determining when somebody got infected. Probably you wouldn't know, but for those that you're longitudinally following, even if you didn't know the time they got infected, but they got into your program, they've been with you for a longer time. Do you still pick DNA positive samples after a long time of having the infection? That's from Kamara.
So I want to assume that in this case, you have patients, these are people who are already infected. Now, hepatitis C, for patients who are infected, as you mentioned, we may not be able to identify the time of infection, but once they are in the chronic phase and they're currently infected, yes, the PCR test is able to pick this infection once it's there. But when they have gone through therapy and they are cured, there's what we call the SVR test, which is sustained virological response, to really measure the efficacy of the treatment and to confirm cure. So at that point, after going through either the 3 or 6 months therapy and waiting out for another 3 months post-treatment, they go through this test, and where it is not detected, they are confirmed to be cured. And in most cases, the drugs have 95% cure rates, and a lot of people are usually undetected. So for patients who have been cured or who have gone through therapy and have come up for this test after 3 months, are likely not to have this infection again, except there is a treatment failure, but ideally they shouldn't. Yeah. And just so that my colleague is now on, so I think he can speak.
Kindly make your comment. Come on, thank you.
Hello, everyone. So I'll try and keep it short. So in respect to data management, that's something that is quite key, not just for client management, but also for policy decision-making at the national and subnational level. So in country, we actually have a very robust national laboratory information management system, especially for our conventional platforms. So regardless of what platform is being used, whether it's Abbott, Roche, Hologic, we have a system in place where we're able to pull all the data from conventional platforms, especially for HIV, onto a national laboratory information system. And of course, that has a dashboard that's available to the government and of course, other major stakeholders. For point of care testing specifically, that's something that we just essentially rolled out last year. We're looking at the current options that are available based on the available platforms, whether it's the GenXpert, whether it's the MPMA, trying to identify how best to extrapolate that data from those platforms and actually have them actually interoperable with the National Laboratory Information Management System. So we're actually working on that as we speak, engaging the various vendors to understand what's available and how can we make sure that the systems speak to each other. So that's something we're currently working on that for POC testing. But for conventional platforms, that has actually been established and we're actually leveraging on that as over.
So Francis, you're muted. You're speaking. Sorry.
Oh, sorry. So colleagues, I was indicating that we're running low on time, but we'll take a few more questions before we begin the wrap up. This has been an exciting presentation from Nigeria and the program that you're running to integrate testing. And we've know that actually it is possible to integrate without actually having the collateral worries that you might compromise performance in other corners. Now, the last question is on The other available tests that you're making available to your clients, and this I am trying to summarize a few comments that have come in and questions. The integration process is being done on existing platforms, but you also are trying to make available, that is the general understanding, that some other tests that should happen are actually happening, even if they're outside the available test platforms that you're integrating hepatitis C and hepatitis B testing. Just your comment on the integration of the other tests, not necessarily those that are running on the Gene Xpert platforms, and how it is being handled.
So I'm not sure I really got your question, Francis. So you want deeper insight around the EID test and the other tests?
Yeah, so there are a few questions that are coming in, whether you do antibody tests as well for patients, whether you're doing biochemical testing as well for some of the patients that you're handling. And so in terms of integration, and making sure that this is actually happening in an integrated way, you could just share with us how these other tests are being handled amidst the integration of the PCR testing on the Gene Xpert platforms that are running.
Okay. So for the other test, you just use the laboratories, which already exist in providing these services. So, we as CHI, we don't really work with these patients, but what we do is to strengthen the healthcare system, working with the ministries of health, providing that technical guidance and assistance, and training healthcare workers. So technically, what we do is just, in this regard now, the lab already provides these tests. So they already have this test occurring in the laboratory. The challenge is when it comes to the viral load testing, the molecular testing, they now have to make referrals to centralized laboratory. So ideally, these other tests are happening within the facility. We're just leveraging those existing tests going on. But where you have the gap is when you have to make these referrals to a centralized site for diagnostic testing. So that's where the gap really is. So we don't really have much problems around it. And just to say that our focus being hepatitis C, which is largely out-of-pocket driven, so we're not providing any form of free tests for hepatitis. So patients pay out of pocket. What we've done is to market shape around the cost and also ensure that they're available within the facility once they are needed by the patients. You're muted, Francis. Sorry.
Yes, so thank you very much, Agwuocha, for this very informative presentation, and your team from Nigeria. Kenneth was giving really very useful responses in the chat, and Kama that are supported with the data management from the back end. I'll just give you 30 seconds to give us your parting remarks, Agwuocha.
Okay, thanks, Francis. So really, I will just I'll say thank you for this opportunity to share the work we have done in Nigeria. Also thank not just me, but I and my colleagues and I, global and national space, working together to bridge the gap of hepatitis space. But considering hepatitis is largely symptomatic, so I want to encourage everyone to get tested, know your status, share the word around, tell people around you to get tested and know their status, and to be linked to early diagnosis to avoid, coming down with end-stage liver disease when therapy may not be beneficial to the patient and will be too late. So I think that will be it, and also for us to continue to advocate at all levels to see how we could draw the attention of donors to hepatitis to really address this burden that we have seen. Yeah. Thank you so much for this opportunity, and hope to.
Thank you again. Thank you very much. And team, we're getting to the end. Your code for accessing the certificates, for those that may be interested in having a documented evidence of having attended this session, is on the screen. Please get to the website and be able to get your copy of the certificate. The slides will be made available through the mails that you shared with us during the registration, but also through our other social media platforms. Thank you again, and we'll see you when we have our next session that will be advertised and made available to you. Thank you for today, and over.